Distinguished colleagues, friends, I would like to introduce our humble experience that we accumulated and to discuss the specificity of real-world data collection in the treatment of patients with different malignancies. So this is the data of clinical practice. Before we transform it into the evidence, first we need to be sure that this data is valid. So definitions were already given today. Yes, we already spoke about it. What data is available? Look at the patients. Patient has a diagnosis, malignancy. So in what systems and who could be the owner or the holder of this data or this information, and how they organized? Well, mainly this is state insurance. This is federal and territorial foundations of medical insurance, and they have the data about the facts of hospitalizations and referral of the patients to the outpatient care. These are medical information system of the outpatients of the oncology centers, and we speak about oncology dispensary first of all. And now registers or registries or databases about the reimbursement. So these databases are carried out by the regional authorities of the healthcare, and the patient can get high-tech care. And this is VMP portal. This is something for Federal Ministry of Health. This is monitoring system, and also for oncology patients. What is very important, final point, is survival. And actually, the reasons and the date of death should be also included into the databases of registration offices. So the outcomes, you see, they're also quite sporadic. Since 2021, maybe doesn't look very impressive, but since 2021, this system actually became into dichotomy, and now federal medical institutions, they refer their data to the federal foundations, and territorial, they refer to the territorial foundations. Now we have two holders of the data. Well, definitely the federal could refer to the Federal Medical Organization for one service, and then for further treatments, it could be the other. He could move to the regional or to go back. So if we speak about one patient, so the data is in quite fragmented and separated storages. Now a bit more detail about some of them, which are the most important. So this is OMS system. Now this order is not relevant anymore, and the other one is active, but the point is not changed. In OMS system, electronically, in a very well structured way, according to the reference books, we say that there is data, some diagnosis, TNM stage, etc. So whether it was drug treatment, about the days and dates of hospitalizations, this is very important, about the outcomes, about the, let's say, hospitalization or the day care, and about the drug treatment of the malignancies. Here we have some more data about the schemes of treatment, about the dates, about the drugs that could be used, and about some contraindications. What we don't have, we have no doses. So this is the same ID for the patient, and now you can understand how patient could be in different entities in a different medical organization. So in fact, de facto, this is a personalized medical care, and option to work with this data in that personalized way, where according to this identifier, we can follow the track of the patients without getting personal data, name, surname, or other personal data. Yes, there are some specificities of the federal organizations, but in fact, the system is structured. Now about the validity of data. Our experience shows that This data, well, I'm saying what is available now, not about what can happen, but what is available now, what we can take and try to work with that. So the best valid possibly, because all these data, they are linked to the reimbursement, and we understand where at every line of database, medical organization is getting some money, plus control. This data is quite valid. So reimbursement. Well, this is by the Petrov Institution data, we see that the databases are organized differently and they are structured differently, but nevertheless, common thing what we can get here is a diagnosis. These are dates of vacations of particular units that patient is getting it, then the fact of getting it, we cannot follow the fact. So the source of finance and additional from data. The chronology of getting these or those treatments according to the reimbursement programs and the other, their personalized identifier, which is SNILS. So putting together, it creates particular challenging. So these are the same patients and they go to oncologists regularly, so they prescribe reimbursement prescription, so they go to the pharmacy, but they never match these time parameters. It becomes very difficult, almost not possible today. And I think not much should be done in order to make it possible. And technically, it's easy to implement. Now, high-tech medical care, it is very clear that the patients can get surgeries, radiotherapy, and federal, and also go back to the entity for the continuation of treatment for the patients suffering from oncologies. And this legacy is important because it influences the outcomes, and definitely this data is important. This is system of VMP monitoring with the Ministry of Health of Russia. What can we do here? Again, electronically. Again, it's all electronically. So this is the diagnosis, medical care. So this is called so-called type and the model of VMP. And some copies of primary documents that could be seen, and the identifier here is at the same time, we have some data about the SNILS and OMS paper. And well, actually, it's not much to do. So these are basic blocks where the patient is getting therapy, including drug therapy. Registers of the patients, so-called cancer register, which is approved by the order of the ministry from 1999. It is clear that the time is ticking, everything is changing, and some updates are already coming. But in the registry, what do we see there? The diagnosis, the stage, cases of providing care, types of treatments, again, dates of hospitalization, some drug treatments, and what we don't see in any other databases, these are reasons of death and date of death. And this is the final outcome of any oncological disease, and we are looking at overall survival. Again, here, identifier of the patients, that's internal code based on some internal rules of the provider that is providing this automatization of the register and doesn't allow to match it with the other sources of data, which complicates the picture here because, in fact, we don't see the whole patient journey and it's more difficult to assess the efficacy. But at the same time, vertically integrated medical system and the common information system in the healthcare, mainly they should enrich us by the data of the real practice because this is a clearly structured reference book and there is a huge scale done according to the internal pharmacological control, so-called SAMT, structured medical data, which is getting to the VMS system. And I believe that upon development of this approach in different oncological areas, which is already ongoing, we will have more massive of real data of real practice, specifically from VMS system, and possibly somehow it will be later on integrated with other sources. But yet now today, we cannot consider VMS as a full-fledged and comprehensive source, and we need to combine it with what we have. By now, we're accumulating decent experience in merging the data, and I wanted to show just several examples based only on the data. So clinical guidelines are changing the practice. Yes, totally agree. And in oncology, it happened just for 3 years. So this is real clinical practice from January 2019 to December of 2021. So that's the story of 3-year treatment for all the patients that were going through OMS system in the 11 entities of the Russian Federation in the Northwest Federal Authority. So this is not the sampling. This is actually general representation. So schemes were classified within several types. Here is chemotherapeutical, let's say, as oncologists saying standard treatment, and also schemes to use monoclonal antibodies and combination of chemotherapeutical and monoclonal antibodies. And here you can appreciate that in January 2019, the share of these very modern schemes of treatment was less than 20%. By December of 2021, we see that these are half of cases with the use of modern oncological treatments. So when we speak about the availability, I think this slide demonstrates very illustratively how the access improved for the modern anti-tumor treatment. Yes, access is getting much better. That's fantastic. That's fantastic. This is not real-world evidence. Well, this is statistics. This is raw statistics. Yes, this is mainly RWD than RWE. So actually, we cannot make any solid conclusions from here, and we're not processing it, and so this is no constatation of the fact. So, and we need to structure that drug treatment. This is drug treatment for lung cancer. So dramatic changes. If monoclonal antibodies they were not used, so by now the share is coming to the half of cases. So this is drug treatment using modern drugs, those that are mentioned in the clinical guidelines. And where you said clinical guidelines, and there is option to control, and this is a basis for the requirements. Well, here it is.
Пример, поэтому, конечно, за 3 года произошли существенные изменения. И еще один крайний пример – это то, что является реально жизнеспасающей технологией, это лекарственная терапия.
And another example of life-threatening, this is metastatic non-resectable melanoma. First of all, number of cases reached 100 in January. The drugs that prolonged the life of these patients were less accessible. So few patients died very soon, patients died and treatment was over. So, and these are cycles of chemotherapy, and all that happened due to the modern drug treatment of monoclonal antibodies in combination. So we can say very confidently.
Например, хотя бы по меланоме с позиции лекарственной терапии исполняется в более чем 90% случаев. И это данные системы ОМС, это то, что оплачено, это то, что было получено. И,
this is something which was obtained, and this is something which was reimbursed, and all of that is quite valid. So these are illustrations. And analytics of RWD allows us to get it when we facilitate our activities with this data. And now conclusions, very briefly. The collection and processing of data is yet done